Okay. Welcome back, everyone. Hope you had a good coffee break. We turn our attention now to clinical conundrums and dilemmas that are faced by sports cardiologists. We had a fabulous screening session. I hope we will be able to parallel that now. We'll be talking about methods by which we differentiate physiology from pathology as far as the cardiomyopathies are concerned and myocardial scar. And it gives me great pleasure to introduce Dr. Sarandeep Marwaha, who is one of our huge list of fellows, probably one of our latest fellows who's just got a PhD, who's going to be presenting her research on athlete's heart or dilated cardiomyopathy, what her research has shown.
Thank you very much for the introduction, and thank you very much for inviting me here to speak. I have no disclosures, and like Prof. Sharma has said, I'm just going to talk about the CRY research over the years, what we have done, and what we have looked at with athlete's heart and differentiating it from dilated cardiomyopathy. As I said, no disclosures. So why does it matter about differentiating the DCM individuals from control? So as you can see from your left-hand side, there's a dilated ventricle which has an ejection fraction of 52%, and you have the athlete, which is a control athlete with a dilated LV, but with an LVEF of 61%. And we have shown worldwide that you get athletic remodeling, which can mimic a dilated cardiomyopathy. So it's okay when the LVEF is normal. But as you can see from this one, the gray zone, there's a number of individuals or athletes that will have a dilated LV, but also with an ejection fraction of 52% because they've trained so hard, and to support their stroke volume at rest, it may look a bit sluggish. So how can we differentiate between the two? And up to 11% of athletes have been shown to have a mildly reduced LVEF and a dilated LV. And why do we worry about a dilated heart if it's only mild? Up to 2% can have a sudden cardiac death if they have mild LV impairment. And this increases if there's associated fibrosis. So this study looked at mild DCM with a mean LVEF of 44%. And what they found was that if there was LGE fibrosis on cardiac MRI, this had increased the sudden cardiac death fold to up to 17.8%. So if we miss this in a athlete, it can pose a serious risk. So back in 2018, it was a CRY-funded study performed by Lynn Miller, who looked at 84 athletes, and they devised this algorithm which looked at NT-proBNP, ECG, Holter, exercise, and CMR. And they proposed this algorithm to basically differentiate between DCM and athlete's heart. On the right-hand side, you can see that the main finding, or the most valuable finding of this algorithm, was a stress echocardiogram, which looked at the augmentation of LVEF when they did stress echocardiogram. So in this study, 79.2% of the control athletes were able to augment more than 10%. 96% of gray zone athletes were able to augment this. But what it highlighted was that although there was an ability to differentiate between the two, 23% of DCM individuals were also able to augment this LVEF. So this poses a problem because we don't want to miss these 23%. Also, when you look at the true positives, what you'll find, some of the investigations, they were quite low, 29.4% for proBNP, 29% for Holter monitor. And the overall sensitivity was approximately 80%, although it gave a very high specificity. So there was a lot of room for improvement here. And plus, this was a very small study. So what did we do? So in the last 3 to 5 years, we looked at 725 patients with dilated LVs that had come through two tertiary centers. Of these, 182 were deemed as athletes, exercising for long periods, over 4 hours, with a mean exercise duration in a week of about 8 to 9 hours per week. 62 of these were classified as control, where they had a normal LVEF and dilated LV. 58 was considered mild DCM, so they've had a previous diagnosis or confirmed diagnosis of DCM. So either they've dropped their LVEF or they've had a genotype positive or a significant family history which has confirmed that they have a dilated cardiomyopathy. And 62 patients was a prospective where they were getting referred to these tertiary centers for identification of whether they were healthy athletes or DCM. These individuals didn't have any form of symptoms. They were quite well. They had no family history or any other inclination that they had a dilated cardiomyopathy. So what do? We put all these 182 athletes through these tests. So same protocol, proBNP, ECG, 24-hour Holter, stress echo, CPET, and CMR. We assessed to see whether the original algorithm was appropriate and also to see if we could improve this. So when we looked at proBNP, the standard cutoff is 125, where you need to get suspicious that this might be a heart failure patient. That is the ESC kind of guidelines, and that's what was used in the pilot study. But what we found was 75% of DCM individuals will have a normal BNP. So that's not really going to help us there if it's keeping at 125. So we lowered this to 95, and this increased the sensitivity to from 24 to 55.2% and kept the specificity of 93.2%. So in our first step, we decided to reduce the proBNP. Then when we look at the ECG, we compared it to the international guidelines to see what was sensitive in differentiating between these individuals. Now, atrial fibrillation, the rhythm or the heart rate didn't have a high sensitivity to differentiate any of these, but what we found was QRS duration was sensitive in terms of you had a lower QRS duration in control than gray zones. But specifically, if you looked at the ECG and looked at left bundle branch block, low QRS, and fragmented QRS, we found that these were the three findings on ECG that may differentiate between a healthy athlete and a DCM. We didn't use the QRS duration because the sensitivity was very, very poor, 26%, and the specificity was of a good standard. But at least with these three parameters, sorry for the spelling mistake there, the sensitivity was 69.2% and the specificity was 96%. So we decided that actually this may be more warranted to used in the algorithm rather than ventricular ectopics or T-wave inversion. So we changed the criteria from the original to include left bundle branch blocks, more QRS and fragmentation. But to note, 40% to 60% may have a normal ECG. And in our study, 40% of DCM individuals did have a normal ECG. So we can't use ECG alone. Now, going on to the Holter monitor, mean ectopic burden on a Holter monitor controls, it was approximately 40, DCM was 925, and gray zone was 617. So you may think that's valuable, but if you look at the chart there, you'll see that there was a huge standard deviation discrepancies with our DCM and gray zone individuals. And some DCMs would have a very, very low ectopic burden on a Holter monitor. The original cutoff was 500, based on other previous studies in Italy. But if you look at here, if we reduce the cutoff of VE burden to 200 plus or minus non-sustained VT, this would increase our specificity, but also maintain, it's still a low sensitivity, which shows that you can't technically use this on its own. So we changed that on our third step of our algorithm. Now, the most interesting part was our stress echocardiogram that we did when we put all of these cohorts through it. The controls happened to show the most increased augmentation with a mean LVEF of 21% from rest to peak. Gray zones were the next, which increased by 19.8%. But DCM was only able to augment 5.4% of their LVEF from rest to peak. They were not able to hit that 10% target. Bearing in mind, 20.6% of DCMs were able to augment from rest to peak. So again, there's a cohort there of DCM individuals that can do this threshold. But when you look at submaximal, i.e. from 80% of their peak heart rate and the change they make from that to their maximum peak heart rate. 98.3% of controls were able to continue to augment their LVEF from the 80% of the target heart rate onwards. So it's actually that submaximal to peak that's really important. Gray zone athletes were able to augment 90.3% of gray zones were able to augment this. DCM individuals, only about 2% were able to augment that. So 98.3%, we noticed that they actually started to reduce their LVEF from 80% onwards. The sensitivity of using stress echo alone was 98.2%, and the specificity was 98.4%, which shows that this is a very, very good test to do in these individuals. Now, what is the value of CPET? The previous pilot algorithm didn't actually include CPET because what we found in that study was that DCM individuals, or highly trained DCM individuals, were able to have quite high VO2 maxes. And in fact, in this study, we also found that actually there's a proportion of DCM individuals that can reach high parameters. But if you look at them individually, it doesn't differentiate. But if you look at 3 parameters, VO2 max, mils per kg per minute, anaerobic threshold, and VO2 max predicted, if they are able to achieve all 3 of those and go above those thresholds, then this had a very high sensitivity of 84.6 and a specificity of 72.6%. So we felt that this could be included in the algorithm. When we looked at cardiac MRI, so apologies for the very small circles here, so hopefully the eyesights are good. We found that 4.8% of control healthy individuals had fibrosis, i.e. major fibrosis. So this is not RV insertion point, this is mid-wall fibrosis on MRI. 43% of DCM individuals had scar. Most of these were actually either mid-wall of the septum or mid-wall of the septum and inferior wall. But 9.6% of gray zones also had scar. 4.4% was subepicardial, but you can see that 3.3% of the gray zones were also subepicardial. So this might depict a previous myopericarditis situation here. What it showed was that fibrosis being present was a helpful marker, but actually the distribution or the scar where it wasn't a good marker because the numbers were so low, and that didn't produce a high sensitivity if we went in terms of where they were. So it was included. So if there's presence of major fibrosis, it gives a specificity of 95.1%, but it's not very sensitive to diagnose DCM. Almost 40%, like I said, was found in DCM, and most of it was in the septal. So when it comes to volumetrics, we looked at that in CMR. If you look at LVEF or LV stroke volume alone, it doesn't help. But what we found, if you looked at the RVEF, it's quite a useful tool. DCM don't tend to have a higher right ventricle ejection fraction. And we felt that 66% was appropriate. Again, RV stroke volume, if it was indexed post-leg exercise and then trying to see what their stroke volume does, if they achieved 66 mils per meter squared or above post-exercise, it was quite a good demarker. And again, left ventricular stroke volume. So left ventricular stroke volume, right ventricular stroke volume, and right ventricular ejection fraction are very good demarkers. And interestingly enough, if they go above 65, or so achieving 66 mils per meter squared, it's actually a good demarker if you use all 3. So they have to achieve all 3. So it's kind of clearly demarking that you need to have some sort of symmetry here when it comes to an athlete. So this was 86.2% specific and 76.3% sensitive. So Prof. Sharma is going to go through the up-to-date in terms of algorithm, but if you put it all together, I'm sorry that it's quite small there, and you go through each serial test, it eventually gave a sensitivity of 95.6% and a specificity of 96.9% specifically. But if you use it in serial testing or like a parallel type of test, then it becomes higher than this, and it goes above 98%. What was the other considerations in my study that we found? Sex differences. That's often a question. So are females able to augment the same amount of ejection fraction as the males? And in fact, they are. If you can push them and they're true female athletes, actually they're able to augment their LVEF appropriately. So there wasn't much difference. But as you can see, the DCM cohort are much lower than your gray zone or your controls. And when you look at their VO2 max, similar, women are able to achieve very high VO2 max. If you concentrate on the DCM individuals, you can see that a large proportion of them are still getting over 30 mils per kg per minute. So like I said, you can't use this alone, but you have to use the other CPET parameters I've mentioned. Drug use. So we always talk about this as a controversial kind of thing, and it's really important in our athletes to find out whether they're using drugs or not, because what we did find, although it's not a huge factor, but there was a difference between them, and there was a significant difference in terms of p-value, that actually anyone that was taking anabolic steroids would have a lower resting LVEF than the ones that had no drug use at all. Bearing in mind, this is not current drug use as well. This was actually lifetime consumption of ever having anabolic steroids. And finally, alcohol use. Again, in the study, we took a history of their daily intake, their weekly intake, their monthly intake, and actually their lifetime consumption. There is bias involved in this, but so is cigarette use. Cigarette users also have bias in terms of recall. But it was done in terms of incremental, in terms of the years, university years, so they were roughly able to remember. And what we found was there was a higher total lifetime consumption in DCM individuals, almost 30,000 units, whereas controls had almost half of this. And gray zone was very similar to controls. And what we found was if you consume 25 units per week or more than 3 units per day, this was probably associated or had some factor in having some abnormal myocardial reserve. And the biggest point was if you could adjust this to age, having 270 units per year adjusted to age was actually probably the most sensitive and specific. And that actually gave a sensitivity of 71% and a specificity of 64%. So it's not as high as what was used in the algorithm, but actually was quite an interesting finding. So the main conclusion of this algorithm was that if we used it in a parallel and a serial type of testing, and hopefully we're developing something a bit more advanced where you can form an application, it creates a sensitivity and a specificity of more than 98%. And what I want you to take from here at the end of this is basically gray zone, and whether you're trying to differentiate physiology or pathology is actually multifactorial of a lot of things: family history, ECGs, echoes, CMR, exercise response. And you have to put it all together and take a good, effective history of drug use. And actually, it's a spectrum rather than it just being one or the other. And so as you can see, there's many shades of gray. Thank you.
So thank you very much. We will have the